All right, guys, my first asynchronous teaching hiccup. Trying to record audio over old PPT format. No good. You got to do the new PPTX. Learn my lesson. So sorry for the delay, but I promise take two will be even better. Read the book. Any questions about oral surgery can typically have their answers found in this book. Hupp et al. Fantastic read. Lots of good practical info in there if you have an interest in oral surgery or just want to provide good care for your patient family now and when you graduate. This is a good book to read. This isn't a weird, random bonding topic. This is bread and butter, how to help your patient during a pandemic, how to jack teeth, how to treat infections. Got to read it. Indications for tooth removal. So certainly advanced, non-restorable decay, cracked tooth, vertical root fracture, very common chief complaint or referral, reason for referral that I'll get on middle-aged and older people for molar teeth. Pulp necrosis, endodontic failure, so dead tooth that they don't want a root canal, or failed root canal that they don't want a retreatment. Severe perio disease, orthodontic reasons, pretty common to take out, bicuspids to create space, or a tooth that's just way out of position, a hopeless, impacted tooth that's in the way of orthodontic tooth movement. Malpositioned teeth, teeth can sometimes be causing cheek biting, lip biting, unesthetic or pre-prosthetic concerns. Additional indications include impacted teeth. Certainly not every impacted tooth needs to come out. If a patient's fully grown and there's an incidental finding of an impacted tooth that can't be probed, doesn't have any pericoronal radiolucency around it, reasonable to monitor that tooth. Wisdom teeth are a different scenario when it comes to a growing patient. If you think there's a reasonable likelihood that they're going to continue to grow in development, as most of them do on average to the age of 26, it makes sense to do it preemptively to prevent all the pain, swelling, and infection associated with partially erupted or erupting third molars. But certainly lots of good reasons to take out impacted teeth. As mentioned before, orthodontic reasons. If you have an impacted tooth and the patient wants to have orthodontic tooth movement, you can't have impacted teeth in the way. It'll cause root resorption of the teeth as you're tipping and torquing teeth in and around that area. Similar thing for supernumerary teeth. If they're in the way from getting proper occlusion or impacted in the way of a good orthodontic plan or pathology associated with them, very reasonable to get them out. Teeth associated with pathologic lesions, as mentioned, cysts and tumors, obviously going to be a reason for biopsy and then definitive management depending on the etiology or sort of the histopathology. Pre-radiation therapy, so certainly any teeth that you don't think are going to make it through the duration of the patient's radiation care, knowing that things only get worse post-rads, sort of long-term. If there's a abscess tooth or hopeless tooth, you want to get it out 2 to 3 weeks prior to initiation of radiation therapy. Anesthetics, economics, certainly not every tooth that can be saved, practically can be saved financially, and certainly there's nothing wrong with a cost-effective extraction to remove a potential source of pain and infection. These are all relative contraindications, so unstable cardiac disease, once again, if you have a patient that's truly has an infected tooth, in most situations you're going to find ways to manage everything on this list. Ideally, unstable cardiac disease would be managed by cardiology, worked up, diagnosed appropriately, and then intervention made appropriately, like stent or angioplasty if possible. Unstable diabetes, certainly ideally you want your glucose controlled perioperatively to help with healing postoperatively and to prevent diabetic complications like DKA or HHS. Uncontrolled hyperthyroidism, pretty rare to see this, but certainly The patient's displaying symptoms of uncontrolled hyperthyroidism. You wouldn't want to be doing a stressful stimulating procedure and injecting epinephrine. You want to get that controlled, see them back, and take out the tooth once it's controlled. Immunocompromised patients often do need extractions, and when you liaise with whoever is providing with the immunosuppressive care, you can then either make the decision to continue them on the immunosuppression and cover them with perioperative antibiotics, or go through a brief period where they don't take their immunosuppression for maybe a couple of weeks after the extraction until some primary healing has happened. Coagulopathies can often be managed in conjunction with hematology. In pregnancy, certainly not an absolute contraindication. We typically try to avoid the first and third trimesters and extract teeth during the second trimester because at this point, baby's fully formed, but you're least likely to induce a preterm labor. Other relative contraindications, so previous radiation therapy to the jaws, unfortunately, sometimes patients still need extractions, in which case they're at risk of osteoradionecrosis. Overall, about 5.4%. Typically do not send them for perioperative hyperbaric oxygen anymore. IV bisphosphonate therapy, certainly a risk of bisphosphonate related osteonecrosis of the jaw, or medication related osteonecrosis of the jaw, known as MRONJ. Once again, sometimes you will be forced to extract patients that are taking IV bisphosphonates, and you're going to have to discuss the possibility of these risks and take perioperative precautions, including systemic antibiotics, primary closure, and regular follow-up to monitor for MRONJ. Teeth located in a tumor, typically no excuse for this. They're often going to be resected as part of the tumor resection, so poor form. This is what I'm going to be expecting, as well as the other instructors that you'll be doing. Every time you present a patient in the oral surgery clinic is assessing the difficulty clinically and radiographically and discussing that with us during the clinical presentation so that we know you're thinking along the right lines and aware of the difficulty of the procedure that you're about to do based on what you see clinically, as well as on the review, typically of the panoramic radiograph with the oral surgeon. I'm going to want to hear you talking about the location. What's the access like? How's the opening? Is it crowded? It could be a lower incisor, but if it's buccally ectopic and there's nowhere to grab a hold of the tooth, that's a bit of a deal. You got to appreciate that, realize that. How am I going to get my forceps on this tooth? Is it mobile? And you can always tell by looking at the x-ray. That's going to be a clinical finding. The condition of the crown, is there anything to work with, or are we going to be sort of going subgingival with a cow horn to try and get down on the furcation? Things you got to be thinking about. Condition of the adjacent teeth is a huge one. You got to be looking to see if these guys have crowns, MOs, DOs, things that you're going to potentially damage by elevating, and sometimes make the decision not to elevate to prevent damage to the adjacent teeth. And certainly proximity to adjacent structures, inferior alveolar nerves, mental foramens, sinuses, things you got to be thinking about before you start to remove these teeth. Prior to presenting the patient in oral surgery, come have a brief discussion and I can prescribe a panoramic radiograph. Please do not come present the whole patient and then say, and we need a Panorax. Come have a quick talk with me. We'll prescribe it. I get it. Radiographs need to be prescribed, but don't present the patient twice. Come to me for your formal presentation with a Panorax. When we're reviewing said Panorax, we're going to be looking at things like the number of roots, curvature, divergence, thin, slender roots, things we want to be thinking about ahead of time, which can help with our decision to maybe go surgical with the extraction right off the hopper, or the forceps choice. If there's a curved root and we think with a 151 forceps we can extract it in such a way that we complement the curve as we remove the tooth to prevent fracturing the root. Looking for things like hypercementosis and other reasons that we may say this is going to need to be surgical instead of wasting your time trying to do a closed extraction. Here you can see somebody got lucky wiggling out this canine despite significant dilaceration of the root on this canine. Little octopus tooth here, certainly significant flared out multi-rooted molar. likely required surgical extraction in order to get this root system out through the alveolus. When presenting your patient, if you see hypercementosis like this needs to be done surgically. In order to get these club-shaped roots out of there, there's no way to do it in a closed fashion. So even this is called closed extraction technique. Part of it is decision making. So knowing when to keep it closed and when to open it. This would require surgical extraction with the flap, 7-to-1 bone removal down to the height of that hypercementotic area in order to have any hope of getting them out in a reasonable fashion. To persist or pursue a closed technique would be very inappropriate. You're just prolonging the inevitable and increasing the length of the procedure, thus increasing the morbidity and pain and swelling associated with the procedure. Here's a nice guy that certainly could be done in a closed fashion using the appropriate planning, identifying that there's a dilacerated root. With a 151 forceps, you can go buccolingual, rock the boat a little bit, and then with the posterior superior vector, bring that curved dilacerated root up through that socket. You can certainly see it's conical and sort of fused. It's not widely spread like 3 slides ago. And you can see on the next slide, that's exactly what happened in this case. It came out in a closed fashion and very reasonable, but certainly a tooth based on radiographic presentation is one that you wouldn't want to be using the cow horn for because there's no furcation. And you would want the 151 because it would allow you to have that three-dimensional control over the vector of extraction to allow that root tip to come along with the root along that path of withdrawal as you roll that molar out and back towards the ramus. Condition of the surrounding bone, often difficult to comment on radiographically, but certainly if you see periapical pathology, you could see that. You're expecting decreased PDL space in the older patients, and you can often appreciate that on the x-ray. So those are a couple of things that you can comment on radiographically that are going to affect the ease of extraction. Certainly want to have informed consent prior to the procedure, reviewing the risks, benefits, and alternatives. Pain, bleeding, bruising, swelling aren't risks, they're expected. Certainly things like oral enteral communications, jaw fractures, permanent numbness to lip, chin, and tongue, or damage to adjacent teeth are risks that should be discussed with the patient prior to extraction of teeth. So when you're in any procedure, typically, whether it's general dentistry or oral surgery, but certainly in my world in the oral surgery, you got to maintain the principles of asepsis. Do not be having bloody gloves and then reaching over and touching clean items like the chart or a stack of gauze or something like that. You're going to have your surgical area, and if you need something outside of it, you ask a circulating friend or colleague, or you take your gloves off, get the thing that you need, say a suture, open it, and then put new gloves on. You don't be grabbing at stuff outside of your surgical prep area. Absolute no-no. This isn't personal preference. This is infection prevention and control, and it's absolute must. Don't want to see it. Sometimes people will see them touch the sharps bucket. That sharps bucket has about 1,000 patients' different blood on it. Your hand now has 1,000 different patients' blood on it. Do not go back and touch anything on your surgical setup. So you'll be contaminating the whole thing. So just never touch the sharps bucket. It's there to drop sharps into, not to handle. Okay? So just those little things, just keep in mind. It's not hard to get right, but it's absolutely imperative. Absolutely need profound local anesthetic when you're extracting teeth, whether it's closed or surgical. It's the most important part. Even myself, who's doing sedations on a regular basis, my sedation will not be successful without profound local anesthetic. It's certainly the most important thing in order for the patient to come out the other side of your extraction, be it closed or surgical, um, as a happy patient. You got to be comfortable with your working position. You don't want to be reaching up. Um, your shoulders, your neck tired. You don't want to be bending over, wearing out your back. You want to be a sort of a neutral position, working with your elbows approximately 90 degrees, and just have good visualization of the patient back in an appropriate position. And we'll talk about that later on. And put a little pack in the mouth, typically just a dry 4x4 gauze to prevent aspiration of teeth can and has happened. Here you can see a tooth in the left main stem. Anytime a tooth goes down the dark hole, you're going to need a chest x-ray to make sure it's in the belly, because sometimes, even though you're expecting if it goes in the airway for the patient to cough significantly, they could aspirate it without significant coughing and fool you. You certainly want to find out before the tooth abscesses, which it certainly can in the lung. This is going to require consultation with a thoracic surgeon to go down with a bronchoscope to hopefully fish it out for you, if you're lucky. The tools of the trade. So just looking on the tray, starting on the bottom left, you can see the long skinny sucker. That's our Fraser sucker. Then we have our scalpel handle that you can put different types of blades on. Most commonly you'll use downstairs in the oral surgery clinic is the 15 blade. Then we have our number 9 periosteal elevator, our bone file, small and large curette, 77R dental elevator, and a pexo for both the left and right. Crier for the left and right. Looks like a 76S extraction forceps. And then on the far right is the Bishop's retractor. On the top we have some, it looks like Adson's tissue pickups. And then we have what looks to be like a mosquito at the very top middle, followed by the needle driver, followed by the scissors. And then we just have a Medicup, often useful for putting teeth in. Fraser sucker, you can see, has a little tiny hole. That's meant to only be covered when you're suctioning on bone, which is often what we're doing, but certainly if you're suctioning soft tissue, if you leave that uncovered, the tip of the Fraser sucker is less likely to be occluded. It allows it to work better. Bishop's retractor has two separate ends. Often in oral surgery we're using the sort of the big beaver tail end, but sometimes you will use the other C-shaped end to retract the commissure for better visualization of what you're doing. By far the most important tool in oral surgery. Two ends, a pointy end and a broad end. The pointy end can be used for cutting through periosteum. Typically you're using your 15 blade for that, but you'll get the odd little area where things are held up and you can use the number 9 mole periosteal in a cutting fashion. This allows you to develop your flap in a subperiosteal fashion. Also allows you to do other things like retract with the broad end, or even sometimes take out little root tips with the pointy end. Overall, fantastic instrument, which will be used on a regular basis, as I said, for developing subperiosteal flaps, but also for just going around teeth in your first step in an extraction, where you go around the sulcus, releasing the junctional epithelial attachment from the tooth of interest. After you've gone around the tooth with the number 9 periosteal elevator, you often elevate the tooth, assuming the neighbors are good candidates to have a little bit of equal opposite force placed on them. The end of the 77R is C-shaped. You can see the little serrations on the end of it, or serrations, and you will place that those serrations towards the tooth of interest, and you'll often roll the top edge of the elevator towards the tooth that you're elevating, as opposed to the bottom edge kind of like prying it out. That's poor form. You're typically rolling towards the tooth. And often once you get a good purchase in between the teeth, you want to hold that pressure, and this will really make a big difference as far as expanding the bone and expanding that PDL space, and really makes the third step, which is typically using the forceps, much easier. Criers and apexos, not used that common, but certainly have their role. Criers are often used, say you're taking out a lower 6 and you get the crown with the mesial root, the distal root's still there. You can put the crier in through the socket where the mesial root used to be and use the pointy end to guide the distal root out. So fantastic use when you need it. Apex elevator is often used for high undeveloped wisdom teeth to really reach up and get a good vector of control to bring it down. So certainly something when you need it, you really want to have it. But those are typically the two instances I'll use these instruments in. Curved hemostat, sort of a bigger version of mosquito, can be used for all sorts of things, picking up teeth, grabbing soft tissue. You can use it to help clean out granulation tissue, follicular tissue, all sorts of good uses for hemostat. 76S forceps, sort of your workhorse forceps, can be used to extract almost any tooth. Other forceps that can be used for more specific teeth would be like an 18R for your right maxillary molars, an 18L for your left maxillary molars, a med anterior for your lower incisors and premolars, and either a cow horn for your lower molars or a 151. So re-listen to this audio clip, write all those down. You need to memorize them initially, and then personal preference will allow you to broaden your choice of forceps from this starting point. Comparing the beaks of a 76S, where they're both smooth compared to an 18R, which is an anatomical forceps intended for right maxillary teeth. You can see the beak that's meant to go on the buccal of the maxillary molar has that extra little indentation on it that's meant to sit between the mesial buccal and distal buccal roots, as opposed to the other beak is smooth because it's meant to go along that single palatal root. As mentioned, this guy is good for lower incisors and premolars. As mentioned, this is good for lower molars that have a nice furcation, allowing you to get these beaks down in that furcation, getting a really good grip on the tooth. Sometimes in doing that, the tooth will pop right out, but often it won't, and you'll have to rock it in a buccolingual fashion to extract it. Here you can see the beaks of the cow horn forceps perfectly positioned down in the furcation, getting a real good hold of that tooth. The other option I say for a molar that maybe doesn't have a furcation is the 151 forceps, which is a fantastic option for lower molar teeth. So it's an important concept when you're extracting teeth. Like I said, the 77R often can do a lot of work for you, expanding the alveolus. And then last but not least, you'll roll the tooth out with the forceps. You're typically not pulling it at all, to be honest. It's often buccolingual movements or rotational movements, as we'll discuss later, to expand that alveolus and PDL space until you can tell the tooth is ready to go. And last but not least, you'll just gently remove it from the socket. Easy as 1, 2, 3. So step 1, periosteal elevator quickly around the tooth to remove that junctional epithelium. 77R, wanting to take your time, making sure that the adjacent teeth are of reasonable integrity to withstand the forces of elevation, followed by use of the forceps. So literally most teeth come out with these 3 steps. This will come with experience. Certainly some people won't use enough force, some will use too much and break teeth off. Over time, you'll start to develop a sense of a tooth that's not coming easily, just to abort a closed technique if you find you're having to use too much force, and move on with a surgical, which is going to be more controlled, more predictable, and safer. Even if you have profound local anesthetic block-in, sometimes if you're working on a lower molar tooth, you can translate forces up into the TMJ, which can create discomfort for the patient. I find if your assistant uses their left hand to help support the mandible, often by holding onto the chin, in conjunction with a side action mouth prop, can really help stabilize the mandible, decreasing the forces on the TMJ. Different forces required to extract the tooth. First one is gentle apical force as you seat those beaks as far apically as possible. And then often teeth will be rocked in sort of a buccolingual fashion. If they're single rooted, rotational movement is highly effective, followed last, not least, by traction to remove the tooth from the socket once all the above have been done effectively and expanded the bone. So most maxillary single-rooted teeth, you'll start off with rotational movements with some gentle buccal movements to help shear the PDL off. As you can see, the palatal bone is much thicker compared to the buccal bone, which is why in maxillary molars you do a little bit of palatal force, but more buccal force, just because this bone can expand more easily. Also, if you're going to have a root fracture by taking it buccally, it's typically going to be that mesiobuccal or distal buccal root, and you're going to have nice tension on that palatal root, so you're more likely to get the palatal root out successfully and then have to go after a mesiobuccal or distal buccal root, which are just easier to see, easier to find, and in less dense bone, and typically just easier to remove in general. So long story short, maxillary teeth, center bone of the buccal, you've taken them to the buccal. The mandibular teeth, similar thing with the single-rooted teeth. Often rotational movements can help remove them. Often in the mandible, the buccal shelf is thicker than the lingual bone, so molar teeth are unique in that they're less supported towards the lingual, and often you can make significant gains with your buccal lingual expansion, with more gains towards the lingual, knowing that that bone is thinner. Here you can see it's a cartoon showing the different examples of the movements, apically seating the forceps, buccal and lingual expansion followed by traction, not forgetting the importance of rotational movements with single-rooted teeth. Different variables at your disposal: chair height, the position of the patient in the chair. In ORs at the hospital, in OR4, I'm constantly getting people to scoot up a little bit to get their head on the headrest. Surgeon positioning, so depending on which o'clock position you're at, 6 o'clock, 9 o'clock, 12 o'clock, as well as the way you're holding the forceps, whether you're underhanding it or coming over the top of it. Just realized I said 6 o'clock position in the other slide. Highly recommended not to assume that position when treating any patient, really. Principles of positioning allow you want to be in a comfortable position so that I say you're not reaching up, you're not bending over. Just puts you in a more neutral position, decrease the pain associated with your own body after a long day of extracting teeth, but also just allows a more ergonomic position in that moment to generate more controlled power. These are pictures of me when I was a resident. More hair, nice and dark hair, and a smile on my face. Textbook would suggest that with maxillary extractions, you want your occlusal plane at an angle of 60 to 90 degrees to the floor. And I would agree with that. That's the position I like to put my patients in. This has the patient back fairly far, which is helpful because if you're working an upper tooth, if you don't have the patient back far enough, you have to almost look down, under, and back up at the tooth that you're about to work on. So the further back, the easier it is for you to see, easier it is for you to work on the patient. You can either use a Bishop's retractor to retract the soft tissues, or commonly you can use your thumb and your index finger to hold those soft tissues back. It also gives you the added benefit of that tactile feedback, because you can often feel those roots moving as you're moving that tooth buccal-lingually, and you can kind of get a better sense of what's working, and just helps you really guide that tooth out. For mandibular extraction, you can have the patient seated up a little bit more. The textbook would suggest with the occlusal plane parallel to the floor. In my books, that's a little bit too high. I like the patient back a little further. And in general, I do find students have the patients seated up almost 45 degrees. So in general, you want to have them back so that you can see exactly what you're doing and you're comfortable. Obviously, if a patient has congestive heart failure and can't go back or has a back problem, different scenario. But all things being equal, typically further back is better for your own visualization, for your own ergonomics, and your own access. When the tooth is out, you often want to go in and make sure there's not any sharp areas. A bone that requires smoothing or alveoloplasty, give the socket a good squeeze. You expanded the alveolus to get the tooth out. You want to give it a squeeze back to prevent undercuts. You never know when down the road they might be getting a denture, and it could prevent secondary sort of alveoloplasty if you do it at this moment in time. If you're doing multiple extraction, it's good to extract the maxillary teeth first for multiple reasons. The first is your local anesthetic will be working here faster than it will in the mandible, so that way you can get going on the maxilla while your inferior alveolar nerve blocks are setting in. So it's efficient use of time. The other thing is if you did your mandibular teeth first, you'd have a bunch of extraction sockets sitting down there, and you can picture yourself extracting the maxillary teeth. Of course, gravity is going to take things down, not up. So a little bit of amalgam, little bits of teeth could go in those extraction sites on the lower that you've already done. But if you do the mandibular teeth second, this is obviously less likely to happen. Just finishing things off here, you can see an example of a case I did with Dr. Valley of a patient that came to see me with an implant already in situ in the 1-1 position. Unfortunately, had some stable bone loss associated with it, and they were wanting me to take out the 2-1 right next to it. So the plan was to do immediate extraction, implant, and immediate temporization with Dr. Valley. So when you're going through the proper presentation format on the slides above, you're going to be thinking access, visibility, patient's ability to open, condition of the adjacent teeth. So certainly here, unfortunately, we're not going to be able to elevate due to the fact that on one side we have an implant, and the other side we have an endo treated tooth with a crown on it. So we're going to have to go from step 1 to 3 in this case. So periosteal elevator right to 76S forcep to rotate this tooth out. A bit of a high stakes plan. The reason we're attempting to get the implant in there ASAP is to try and preserve the small amount of bone that remains at this extraction site to preserve that bone volume and of course the associated soft tissues in this highly aesthetic zone. Here you can see tooth out, implant in, and immediate temp abutment placed allowing Dr. Valley to make one of his beautiful temps. So super nice job making this temp. You can see it's intentionally about a half mil shorter than the adjacent teeth. That way when the patient protrudes, this immediate temp will not be in occlusion, making it more likely to fail if the patient could actually protrude on that tooth. So well done, and you can see a great job of preserving those soft tissues, and you can see how happy those soft tissues are around this extraction, immediate implant placement, and immediate temporization, even compared to the adjacent implant that's been there for a long time.